Guys, I just recorded a 40-minute lecture and found out that my audio wasn't working. Okay, so after I let the pillows on my bed understand my frustration, I'm back again with a second and final take. Alright, so welcome to my Paramedic Handbook ECG lecture. My name's Ken, and today I'm going to attempt to explain the theory concept of ECGs from a pre-hospital care lens or a paramedic view. And keep in mind that you should always adhere to your local standards and directions set out by your instructors alike, and know that this is purely for educational purposes, and that I am by no means an expert. I may give out wrong info. I will make sure to follow up and correct myself with annotations afterwards if necessary, but without further ado, let's jump right back into this for the second time. So this is our table of contents and what we're going to cover today in this lecture. We're going to start out with a little bit of anatomy, and then we're going to move on to the conduction, talk briefly about the cardiac cycle. Both of these we're just going to whiz right through. It's going to be more or less high school review. Nothing that we don't all already understand or grasp already. And then we're going to move on to the theory behind or ECG theory. And then we're going to go through interpretation of ECGs, and then physiology. And the part 2 of this lecture, because I've decided to split this, will actually cover the patho and how we can use ECG as a diagnostic tool for a whole plethora of cardiac problems. More on why I organize this the way it is later, but let's just jump right into it. So, cardiac review. Okay, believe it or not, this is the heart. So we're going to start on the left here with our circulatory system. So as you know, blood returns from the top through the superior vena cava, and from the bottom through the inferior vena cava. And then collectively they gather right here in the right atrium, which then pushes the blood through the tricuspid valve, where it collects in the right ventricle, which then ejects it through the pulmonary valves into the right and left pulmonary arteries, where they then meet with the lungs on either side and return through the pulmonary veins. Now you may realize that the veins and arteries in this context are actually inverses of the common definition that we've gone with throughout our whole educational careers, and that arteries carry oxygenated blood and veins carry deoxygenated blood. While that may be true systemically, in the context of the heart, the opposite is true. As you can see, the arteries actually carry deoxygenated blood from the right ventricle, where they then pick up oxygen and return back through the pulmonary veins. So, the all-purpose broad definition of an artery and a vein is that arteries carry blood away from the heart and veins carry blood back towards the heart, irrespective of their oxygen, whether or not they carry oxygen. Okay, so they come back through the pulmonary veins into the left atrium, through the mitral bicuspid valve to the left ventricle before it's ejected through the aortic valve to the aorta, where it then goes to the common carotid, brachiocephalic, and subclavian. Or you may simply remember it as the head of a chicken. Alright, let's erase all that. Okay, on the right here we're going to talk briefly about the perfusion of the heart. The heart is a muscle. Muscles expend a lot of energy. They work. And the heart is a continuously working muscle, therefore it eats a lot of oxygen. It's very hungry. And the reason why this is important is because depending on where an occlusion or an MI, a myocardial infarction may be, it will ischeme different parts, if that's a word, of the heart, which will then respond with arrhythmias that the ECG will pick up, which is the essence of this lecture. Okay, so the three main arteries that we're going to go through, the right coronary artery, going through this auricle right here, and then the left coronary artery going down here, but the other main branch of that would be the circumflex, this way. And of course, each of these gives rise to other smaller arteries, like the marginal, the anterior descending, blah blah blah. Oh, and please note that the bottom of the heart is the apex, while the top is the base, because nothing makes sense in medicine. Alright, so that's that, and we can move on to the conduction cycle. Oh, one more thing to mention for in terms of the coronary arteries. If we flip this heart around and we look at it from the posterior side, unfortunately I don't have an image of that on this slide, but the circumflex will wrap behind this way, and the RCA wraps around that way. So when someone refers to their heart as right or left dominant, they mean, if you can imagine, this is the back side of the heart. There is another artery running between the ventricles. It's called the posterior interventricular artery, or the PIV. This one is the one that feeds the bulk of the heart. So if this artery is a continuation of the circumflex, you are considered left dominant. If this artery is just a continuation of the right coronary artery, you are considered right dominant. The significance is synonymous with being right or left-handed. Alright, so let's talk about the conduction system. So here we talked about the anatomy, the perfusion. Now let's talk about the actual electrical system, the conduction system of the heart. And if you recall from every high school biology class ever, you'll know that the impulse begins at the SA node, and then it actually travels. So you'll recall that the atria contract before the ventricles do. And well, how do the two atria coordinate? Well, it's actually through the Bachmann's bundle. So the bundle synchronizes the two atriums, so they contract synchronously. And of course we have the internodal pathways. They're just different branches of the SA node that meet together at the atrioventricular node, which then sends it down through the left and right bundle branches and then back up towards the Purkinje fibers to depolarize the rest of the ventricle. So the SA node, also known as the primary pacemaker, has an intrinsic firing rate between 60 to 100, and it has a bunch of backup systems. The AV node kicks in at 40 to 60, and the Purkinje fibers firing at 20 to 40. Okay, and this is a pretty cool visual of the impulse traveling. So SA node, Bachmann's bundle, internodal pathways, AV, the bundles left and right, Purkinjes. Alright, so now we have a graphical representation of this conduction system. These are the 4 phases of the cardiac cycle. So this is all of that zoomed in. Each cell of the heart, imagine if this was one cell. Well, actually, let's start by talking about the properties of cardiac cells. And you'll recall that there are four properties: excitability, the ability to respond to electrical impulses; automaticity, the ability to spontaneously generate an impulse. That's the important one. Conductivity, the ability to spread the spontaneous impulse with each other and propagate it through. And contractility, the ability to mechanically respond to an impulse. Uh, Automaticity is the big one. And as an example, let's say someone is undergoing VF. Now, we know to defibrillate this, and defibrillation is a word that's tossed around in every standard first aid CPR course ever. It's what defibrillators, AEDs, and monitors do. But what does it actually mean? A misconception is that defibrillation restarts the heart. While some of that may be true, what you're actually doing, or what the defibrillation, the shock, does, is it artificially induces a period of asystole. So you're killing the heart, or rather you're killing this chaos, in the hopes that automaticity, one of the properties, takes over and restores a normal sinus rhythm. That's what defibrillation is meant to do. So automaticity, very important. Or another way to remember it is that myocytes can generate its own impulse, so automaticity. They can then spread them with each other, conductivity. They can get influenced by nervous stimuli, like inotropic, chronotropic, or dromotropic agents, like epinephrine, or excitability, and then contract as a response, so contractility. And if you remember, the heart doesn't have a true nervous system, so excitability refers to the ability to respond to agents that exaggerate its automaticity, conductivity, or contractility. Okay, let's talk about briefly about the action potential. So the four phases: 0, 1, 2, 3, and 4. So we actually start at 4, which is the resting state, where, as you can see, the inside of the cell is more negative relative to the outside. This is the resting state. It's the resting potential, or membrane potential. It's at negative 90, as you can see. This means it's ready to fire. It's ready to depolarize, and when an impulse, automaticity, kicks in, and there's a high concentration of sodium outside the cell compared to a low concentration of potassium inside the cell. But that changes when there's an impulse. The anions and other proteins inside, or rather, when it's stimulated by neighboring cells, remember conductivity, it propagates the impulse from one cell to another. The cell membrane becomes permeable to the sodium. That's that right here. So what happens when a bunch of positive sodium rushes into the cell? Well, the cell is relatively more negative. More positive is coming in. It depolarizes this. Polarization just simply means the gradient. So it's more positive here, more negative here. More positive rushes in. Now all of a sudden the outside and inside is not so much different. That's why this shoots up from negative 90 all the way to around 15. That's phase 0. And at 1, calcium channels open to maintain depolarization, but at the same time that's happening, potassium is leaving the cell. So if one comes in and one goes out and they're both positive, you have a plateau because there's no net change. Well, eventually it has to stop, so calcium stops coming in, but potassium continues to leave out. So positive ions are leaving the cell, so it becomes more negative. That's why that drops. Until eventually the NAK, potassium sodium ion pump, restores its polarized state back to here. And then That impulse travels from cell to cell to cell. Conductivity. Alright, moving on. Alright, back at it again. So, electrocardiograms. Now we're diving into the theory. ECGs, or EKGs if you're German. So a little bit unconventional. I want to start with Einthoven's triangle before we proceed with anything else. I feel like it's been taught incorrectly or in a manner that rivals deciphering nuclear codes. And it's not, the concept itself isn't as complicated as it may seem. So we're going to start with the triangle before moving on to the four lead. And just as a quick preview, so the reason why I want to start with the theory is because when I show you this picture, this normal sinus rhythm that we've seen all too much before, we all know that this is atrial depolarization, ventricular depolarization, and then ventricular repolarization, right? Well, has it ever occurred to you why the atrial depolarization looks like this? And why the Q wave goes down like this? Or why this is sharp up like this? Why it dives back down? Why is there a pause? Why is this hump shaped? Why am I referring to them as this when they're deflections? All that stuff. So hopefully I'm going to clarify all of that and help you understand how we get from the theory to this pretty picture. Alright, let's start. So Einthoven, his law. Every time a heart contracts, it emits a tiny amount of electrical energy that travels across the surface of the skin. This positive energy is captured by the leads. He developed the first standardized ECG 4 lead. Okay, so there's some stuff to unpack here. From now on and moving forward, leads are not to be interchangeable with stickers. So electrodes will be the new sticker. Leads from now on, and in this context, will always mean views. Okay? And there is a reason for that, which we will get into shortly. But all you have to know is that leads are views. And so when we refer to a 4 lead or 12 lead, we're actually referring to 4 views or 12 views of the heart. Well, actually, I might as well just tell you now. The reason why leads and stickers are not the same is because in a standard 12 lead ECG, we don't have 12 stickers. We actually use 10. A lot more on that later. But for now, just know that leads are views. And this is important because, well, you might ask, why do we have a 4 lead in the first place? Or why do we have a 12 lead? Or 15? Well, imagine I could draw, first of all. But imagine that this is an elephant. Oh my god, that's horrible. So imagine you were to describe an elephant to a person who's never seen an elephant before. And you're standing right in front of an elephant. So that's the trunk, that's the head. Apparently these are ears. And you see the 2 front legs. So you draw an elephant, and that's what you draw. But does this do it justice? No. Because what you're missing is the rest of the elephant. So if you look at it from the side, well, now all of a sudden the elephant looks a lot longer. It may even look bigger. You notice it has a tail. It has two hind legs. And so you see more of the elephant and you paint a better picture, literally. So imagine you have the heart right here. First of all, one lead isn't enough, but imagine if you had one view of the heart. Well, from which direction? Which angle? Front, back, left, right? Or is it diagonal across? Every lead paints a visual or captures the electrical energy from the heart, and it paints a visual of the heart from whichever lead you're looking at. So you essentially capture, it's a diagnostic tool that allows you to view the heart from different angles. That's what a 12 lead or 4 lead or any lead is. And so that's why we have different angles, because as you recall from before, depending on where the occlusion or infarction is, it might not present with in one lead. You might have a better visual from another lead. So let's say, going back to the elephant, let's say its left foot was injured. Well, from lead 1, if lead 1 was looking at the elephant from the front, you wouldn't be able to notice the injury. But if lead 2 looks at it from the side here, well, now you have a clear visual on that injury. Likewise, maybe from behind you might have a visual, but on the other side, on the right side here, you won't be able to see it. So in this example, lead whatever this is, so from this angle and from behind, you might notice this. So similar case with the heart. Not all leads will pick up an injury or an infarct or an ischemic area of the heart. Some leads will. And that's why we have multiple views. Okay? Alright. We'll come back to this. Okay, so what is a 4 lead? Well, a 4 lead is a partial picture of the heart. And remember how I said leads are not stickers? Well, here's a perfect example why. So in this case, we have 4 electrodes. As you recall, white over green, or snow over green, smoke over red. So we have 4 electrodes, but it's a triangle. So why is that? Well, you have to understand that A, lead is not an electrode, sticker, and B, one of these is not like the other. It's this one. Well, I gave it away, it's right here. So a standard 4 lead, it uses the 4 limbs of the body in which you attach your electrode, but it actually only uses the white, black, and red as a lead, and therefore it creates a triangle. And you can refer to the limb lead placements. So the reason why we have, well, in class and lecture we always say, okay, white over green, black over red, blah blah blah, 4 lead, gimme. We ever take a moment to step back and wonder why this one exists? Well, let me tell you. So this one, it's a ground lead. Well, what the hell is a ground lead? Well, it means it doesn't have any actual effect on the ECG reading. It's a point 0 where the electric current is measured, so it's not used in any lead, and its sole purpose is to reduce artifact, noise, interference, static, whatever you want to call it. And then the best example I can give as to why or how this happens. Now imagine you're back in high school in advanced functions or in any math class. Disgusting. So let's say you come across an equation and let's say you have that fraction. plus, I don't know. Alright, well, the first thing you should do when you look at this is that can be simplified into 1 over 3, right? And this is painfully obvious. Why would you want to work with a larger number when it can be simplified? Well, guess what that is. Imagine if you had your triangle action going, and this and this both had interference, static, artifact between the two. This ground lead picks that up, recognizes it as a reference, and removes it. So the end result, or the picture, is a more clear lead or view. And I hope that helps to understand that a little better, but it removes the common same amplitude interference voltage from each electrode here and here. So it removes artifact, which is exactly identical to removing simplifying a fraction. So now the question is it a requirement? Do you need it? Well, do you need to simplify this? No, you don't. You can totally work with this. It's just going to be a little bit more complicated. And in the same manner, you don't need this. Or you can. But it will help reduce some of the interference, and it will paint a clearer picture. So that's why that exists. That's why there's a ground lead. So technically, these three are the leads, as you can see. See how there's not a ground lead here? And that's how we get a triangle. Okay? Alright, let's remove all this. Just erase the evidence. Okay. So there's no rhyme or reason for this, as far as I know, so this is the part where you're just going to have to remember that lead 1 goes this way, between the white and the black. And lead 2 goes this way, between the white and the red. And lead 3 shoots back up this way, right? So like that. Now, you'll notice that it travels in a direction. It goes from the negative to the positive. This is called a bipolar lead. And limb leads are bipolar. They have a true negative and true positive pole. So, as you can see, in this case, in lead 1, the white is the negative, and the left hand, the left arm, the black, is the positive. So the way you can imagine is that if your eyes were here, you're watching it from the perspective of the positive lead. So the view, or the lead, you're watching the impulse or the electrical activity going in this direction. Alright? So your eyes are up here. Similarly, the positive's here, so the eyes are here. So you look at the heart as electrical activity is going this way, but you're looking at it from down here. And so you'll notice that in lead 3, the left arm becomes negative, the pole, but in lead 1 it's positive. Well, it's because it's bipolar. One of these has to be negative, one of them has to be positive. Simplest way to remember, the right arm is always negative, the left leg is always positive, and this flips. Okay? Alright, so the limb leads are the only lead that has a true dipole. So from one electrode to another. But however, from this you can derive more leads. So now we're going to move on to a 12 lead. It's a complete picture of the heart from 12 angles. So now you have 12 pairs of eyes looking at the heart. So how does that work? Well, some things stay the same. Yeah. So this stays the same, right? So how do we get to 12 in the first place? Well, remember how I said leads are not stickers. I know I keep saying this. I really need to preface that. Well, how do we get 12? We have 10 electrodes, but somehow we get 12. Well, here's how that happens. So we have 1, 2, 3, 4 electrodes, stickers, plus 6 across the chest. 1, 2, 3, 4, 5, 6. 4 plus 6 is 10. Well, okay, 10 stickers that we actually place on the body. How do we get 12 views? Well, we already established here, right? 1, 2, 3. It's a triangle. So now we introduce the topic of augmented limb leads. Now that sounds complicated, but all you have to know is that an augmentation, or an augmented limb lead, it bisects, it uses a bipolar limb lead, and it uses the average of the other two as a reference point, and it bisects it. So in this case, right, that one's that, and it goes like that. AVR, augmented, right. Okay, and similarly, augmented left, this one, that way. Augmented foot, that way. So now you have more views of the heart. Now you're looking straight from a frontal plane, this way and that way. Okay, so it bisects a pair of perpendicular limb leads, right, because it's perpendicular. So lead 3, that's perpendicular to it. And it uses the central terminal of Wilson as a negative reference point. The central terminal of Wilson, or WCT, is right there smack in the middle of the heart. Okay, so let's do some math. 1, 2, 3, plus 4, 5, 6, 1 for each augmented. So we have 6 plus 1, 2, 3, 4, 5, 6. These are precordial leads, the one that we stick directly on the chest. 6 plus 6 is 12. Alright, so these are not bipolar leads. Neither are these. So these 6 precordial leads, or chest leads, they look at the heart directly from where they are. So you'll remember this lead here, it looks at it straight across from one pole to another. This one, it uses the central terminal of Wilson, so it just looks straight at the heart, just like that. Right? So now you see we have different planes of view from the heart. So if you can imagine, so that's a cross section. So the augmented limb leads and the limb leads themselves, they see the heart from a front and back frontal plane. These guys, they look directly into the heart, like that. So instead of front and back, left and right, top, bottom, they're looking at outside in. Alright? Okay, that was a lot to take in. Let's go over all of this one more time. Or actually, let's revisit this topic. Okay, so now that we have a pretty good understanding, let's go over this part. Every lead represents differences in electrical potentials between 2 points. So remember, in this case, the limb leads, negative, positive, the difference in electrical potential is measured. For the precordial leads and the augmented limb leads, they're looking at the central terminal of Wilson as the negative reference point. So between 2 points at any given instance during the cardiac cycle. All ECG leads analyze the same electrical activity from different angles. So that's important. So depending on where you are, it will generate different ECG readings. Remember that elephant? I just erased my masterpiece. An elephant can, it could just be grazing, but depending on where you are, you'll have a different picture of the elephant grazing. So similarly, when we go here, why do we have this? It's because this whole normal sinus rhythm, as we so commonly refer to, is actually, it is the average picture of all of these leads capturing the same electrical activity at once. That's how you generate this. So using our elephant analogy, imagine if 12 people, I'm not going to draw the elephant again, but imagine an elephant and we place, so that's the elephant. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Everybody drew a picture of the elephant from where they were standing. If we took the average of all those pictures, we would get a 360-degree spherical view of an elephant. And that is an extremely powerful diagnostic tool, because if you can imagine, we captured most angles of the heart as we possibly could from the outside. All right. Okay, so one last quick review of everything we talked about. So Einthoven's law, every time a heart contracts, tiny amount of electrical energy that we can capture. Leads are views, electrodes are stickers. Now this part makes sense. So standard limb leads, we have 3 bipolar, right? True negative, true positive, negative positive, positive negative. Augmented limb leads, they bisect them perpendicularly on the frontal plane, both of these, and precordial chest leads look directly into the heart. So 1, 2, 3, 4 limb leads, the ground included, plus 6 precordial leads, that's 10 for 12 views. Right? Excellent. All right, let's talk about this for a second. Whoops. If depolarization occurs in the direction of a lead, okay, so now we're going to complicate things a little bit, because I just told you that, well, let's draw it here. The normal sinus rhythm is an average of all of these guys painting the same picture of the heart. Well, what if we isolated them? What if we only asked these guys to paint a picture? Or only asked this guy or this guy? Well, now that changes things, right? Because now we have little bits and pieces of the elephant. We don't have the whole elephant. So if depolarization occurs in the direction of a lead, moving towards the positive electrode, it will generate a positive upright deflection, and the reverse is true. So what the hell did I just say? Well, think about it like this. Let's say we're looking at lead 2, if you recall. I guess it's easier. Well, it's fine. Negative, positive, right? Negative. Oh, negative, positive, lead 2. And remember this. Okay, remember that. Which direction is it going in? The net vector is this way. Oh my god, what a coincidence. Lead 2 also happens to be going that way. That means if depolarization occurs in the direction of a lead, like lead 2, moving towards the positive electrode, right here, it will generate a positive upright deflection. If repolarization occurs in the direction of a lead moving towards the positive electrode, it will generate a negative downwards deflection. The reverse is true. the difference being repolarization. I guess you can't see that. Repolarization, depolarization. This is why the T wave is positively deflected. Okay, so from this we can break apart a couple things. So if that's true, if depolarization occurs in the direction of a lead, that means this guy, whoops, okay. If that's true, then this is occurring in the direction of a lead because it's positive. This would be, and that would be. Whereas this and this would be occurring in the opposite direction because it's generating a negative away from the isoelectric line. Similarly, if repolarization occurs in the direction of a lead, remember this is repolarization, it will generate a negative downwards deflection. Okay? And when I say, so why do I say this is why the T wave is positively deflected? Well, if we use this logic, that would mean repolarization is occurring in the direction away from the lead. The inverse. A lot more on this later. I promise it will get better. Alright, any impulse that changes direction may result in a biphasic waveform. So lead 2 I conveniently picked because it follows the direction of the net vector going this way. These guys do not. So if the net vector is going this way and you're looking at the heart from this angle, a lot of that changes. A lot of the views shifts when you plot it. And so that's what that is. So any impulse that is perpendicular to the lead, so let's say, so if the net vector is going this way, or let's say the impulse is going this way, and you're looking at it from this angle, so that's perpendicular, right? Because of that. It will produce an isoelectric tracing. So if one is going this way, but one's going this way, well, this is neither positive nor negative, so you're just going to have a flat line. Or very little deflection because it's not perfectly perpendicular. So it might be a small bump, and that is why we have, or that explains the tendency of bumps to happen. It all depends on the angle or the view you're looking at. And as you can see, I'm jumping a little bit ahead of myself, but if you can see here, so that's what I'm talking about. So these precordial leads, they're looking into the heart. So look at this. Now notice how it changed. This is the same, remember, it measures the same electrical activity just from different angles. So look at V1. Now look at V2. Notice how it shifts because of the net vector. Positive, 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 negative. The net vector is going this way. So depending on the angle you're looking at it, you're going to generate a different rhythm because you're simply looking at it from a different angle. Okay. Alright, 12 leads continued. So again, 6 limb leads, lead 1, 2, and 3. Lead 1, 2, 3, and then augmented vector right, augmented vector left foot, plus the chest leads equals that. And I don't know if you can see this, but it says normal QRS axis. It's because the net vector goes this way. And I know I keep saying net vector. I'll explain what I mean in a second, but it essentially means, so why does repolarization, or actually no, let's explore this part. Actually, yeah, this is a perfect example of what I mean by net vector. So these are precordial leads 1 and 5. if the impulse starts here, the SA node, and then through the Bachmann's bundle to the left atrium, this guy is looking at the heart from here. So the impulse goes this way. It's pretty perpendicular, but not perfectly, so it's going to generate a little bit of a bump. It's still kind of going in this direction. No, actually, excuse me, other way around. This is V5. Yeah, so V5 is looking at it from this way, right? So if V5 is looking at our heart from this way, and the impulse is going this way, well, it perfectly lines up. So this arrow, the impulse is moving this way, towards V5. It's moving towards the positive. Therefore, it's positive. When the impulse travels across the Bachmann's bundles to the left atrium, it's moving perpendicular. It's kind of moving actually a little bit away from V5, because V5 is looking this way. The purple arrow is kind of going this way. It's kind of going away from this area. That's why it's negative. Remember, right? If depolarization occurs in the direction of a lead, it will generate positive. And the reverse is true. So it's going this way, right? Away from V5, so it's negative. As it depolarizes the rest of the atrium, for the most part, it's perfectly perpendicular, which is why it's isoelectric. And when it reaches the right and left bundle branches, again, moving this way, away from V5, generates the Q wave here. But now, all of a sudden, the hefty ventricles depolarize, and remember which side or which ventricle is dominant. It's the left ventricle. That's where the bulk of the mass is. That's the ventricle that pumps blood to the aortic valve to the rest of the body. So it's bigger. It has more mass. It generates a stronger impulse. So while the ventricles are all generating impulses, this way, 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 this. Okay, this is really messy. Ventricles going this way. There's more of it on this side, and that's what we mean by net vector. Most of the impulse is concentrated on this side, and guess where that's pointing to? Towards V5, which is why we have a huge, sharp deflection positively. And then, of course, the bases of the heart, the peripheries, eventually depolarize. They depolarize away, which is why we generate the S. All right? And as we talked about before, that's V5. That's conveniently looking at it in the same direction as the impulse travels. So if we look at it from this angle now if you can imagine, all of that is not exactly flipped, but it does change some things. For example, the ventricular depolarization, if you're looking at it from this way, now it's kind of running away from you. Not perfectly perpendicular, but it is going in the opposite direction, hence that. And that explains all of these. So depending on which view or which side of the elephant you're looking at, you're going to paint a different picture despite these two being the same. Okay, hopefully that was clear. Okay, what else can I talk about? Yeah, so these views, they all have, so as you can imagine, all these views, these leads, they have clinical significance because obviously some leads can see parts of the heart that the others can't. So for example, lead 2, is actually very useful because it follows the natural net vector of the impulse generated by the heart. V5, so here, or V5 here, and V6, they look at the left lateral part of the heart, which makes sense, right? This is the lateral part, that's the left. V5 looks at it this way. And so what about V1? Well, V1 and V2, they look at the center, or the septal part of the heart, right? Because if that's the heart, they're looking dead center this way, so V2 would be like right here. And if you keep going down, different parts of the heart. And of course, 15 leads, you look from behind, but that's a whole nother topic. So that's the gist of it. All right, I wanted to go over the theory behind Einthoven's triangle, how we derived a 4 lead from it, explain the ground lead, explain the 12 lead, and how we even got to plotting this in the first place, because I think that's crucial to understand. And so now we can move on to interpretation. Okay, now we're back here. So a little bit more theory. That's our normal sinus rhythm. Remember, this is the average of all the 12 leads captured. And let's go over a couple definitions first. So obviously P wave, Q, R, S, T. These are deflections, right? So an interval, it typically, it contains a mixture of isoelectric lines and the waves. So it's a combination of both the baseline and the wave, whereas the segment is just the baseline between waves. So between P, at the end of P and the start of the Q, that's a segment. If you're including the wave as well, it becomes an interval. Okay? And like I said, don't focus on the shape, because as we just explained here, the shape does not matter. It's the concept. So is there a P? And by the way, this is important when we're interpreting. So obviously you can't memorize every single shape, and it's not clinically significant to report a shape. It is, however, to notice that there is a P wave, there is an R wave, and an S, etc. No matter which way it's pointing at, it's still the same because it depends on where you're looking at it from. Okay, so those are called, well, when they occur on the opposite side of the heart, like these, like the precordial leads, they're called reciprocal changes. They're basically inverted, yet it's still the same rhythm, it's just inverted because you're looking at it from a reciprocal angle. Okay, important to note, the TP, so this, and then back over here, that's the isoelectric line. That's our baseline that we're referring to. Okay. That's pretty cool. Now it has to be plotted. So, on a graph, on a rhythm strip, y-axis in millivolts. So one of these small squares is 0.1 millivolts. On the x-axis, we have time. Each one of these is 0.04, so we have 5 of them for 0.2 seconds. And one big box, 1, 2, 3, 4, 5. 5 times 0.2 is 1 second. So 1, 2, 3, 4, 5. This whole thing is 1 second. Okay? Alright, so that's all there is to it. One small square is 1 millimeter in reality. So all that is 1 millimeter. So obviously if you have 10, that's 1 actual centimeter from here to here. And this we already went over. Alright, pretty simple stuff. Okay, now let's go over how we interpret it. So remember, we don't interpret the shape. We never interpret the shape. Instead, because the shapes differ, we interpret based on concept. So we employ the 7-step method. So, rate regularity. We start with this because it's the easiest. What's the heart rate? If you want to cheat, go look at the monitor because it does it for you. Or you can do it manually, like a manual blood pressure. So how do we count the heart rate? Well, it's pretty easy. So if we assume that is ventricular depolarization, and this obviously repeats, we're going to use that as a good reference tool. So there are a couple options you have. The first option, you take 300 and you divide it by the number of large boxes for the heart rate in 1 minute. So let me zoom in on this. Okay, oh, maybe I can zoom in a little bit more. Alright, 300 divided by the number of large boxes. So you want to count, so these large boxes are the bolded grid lines. Okay, so you want to pick an R wave that sits right on one of the grid lines, just for convenience. It looks like that's pretty good. Alright, 1, 2, 3, approximately 3. This small gap is compensated by this small gap here. So it's approximately 3 large boxes. Okay. 300 divided by 3 large boxes, the heart rate here is 100. Let's confirm it by using the second method. 1500 divided by the number of small boxes, so we might have to zoom in a little bit more here. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 1, 2, 3, 4, 5. 15. 1500 divided by 15 is 100, right? Why or how did we get 300 and 1500 in the first place as numerators? Well, because that corresponds to how many of the boxes there are in a minute. So for example, in 5 large boxes, so 1, 2, 3, 4, 5, 5 large boxes per second. Remember? We go back. Whoops. 5 large boxes is 1 second. So if 1, 2, 3, 4, 5 is 1 second, we multiply that by 60, we get 300. That's how that number came to be. Similarly, we have in the same 5 boxes, there are 5 per. So 5 small ones per the 5 big. So 5 times 5 is 25 small boxes in, so you have 25 small boxes in 1 minute. You multiply 25 by 60 seconds, you get 1500. Alright, that's where those numbers came from. Pretty easy. Alright, so I just told you these 2 methods, the 1500 and the 300, they work, but it's going to be difficult if the R isn't on one of these grid lines. So what happens when it's not? Or rather, more importantly, what happens when it's not regular? Remember, rate, regularity, do the complexes repeat? In this case, they do, conveniently, as most should. But what if they don't? Well, then you're going to have to resort to another method, in which case you print out a 6-second strip. So 1, 2, 3, 4, 5. Oh, so these are already marked. So 1 second, 2, 3, 4, 5. Oh, that's perfect. Okay, yeah, actually this is 6 seconds. So that's a 6-second strip. So you just count the number of R intervals and you multiply 6 by 10 for 60 seconds, right? Because this is 6 seconds. Count how many here times 10. So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. 10 times 10 is 100. Right? actually the last option you can do, and this is by far the quickest, you just memorize the numbers. So one large square is 300. So what I'm trying to get at here is you count the number of boxes between, large boxes between each R interval. So let's say there was an R interval here and here. So let's say there was an R interval every large box. So there's one in between each one, then it's 300, right? Because it's fast. There's a lot more R intervals. Let's say it's one every two. So there's one here, right? 1, 2. Well, now it's 150. Let's say, as this example already is showing, there's 3. Then it's 100. So if you remember these numbers, you can just look at how many large boxes are in between each one and then just spit out whatever number. Although, please keep in mind this only works again if these are all consistent and regular. So it follows the same, it holds the same risk as formula A and B. So when in doubt, and if it's ever irregular, resort to C. Okay? Alright, so that's rate, that's regularity. Now we look at the P wave because we're going in order. P waves, does it precede each QRX complex? So does each complex have one? Right here, right here, right here, right here. Yes, it does. Oh, it's also heart rate's 100, borderline tachy, it is regular. P wave, yes we do. PR interval, is it between, so these are numbers you're going to have to know, between 0.12 to 0.2 seconds. So if each one's 0.04, that would be 3 boxes, this one would be 5 small squares. Hard to see here, but PR 1, 2, looks about 3. We're going to say it's good. Is it consistent in length? Yes, it is. Looks about the same in every one. Alright, that's good. QRS complex between 0.06 to 0.12. So that's about 4.5 to, oh wait a minute, 1.5 to 4. I mean 3. 1.5 to 3. Small squares. It's quite narrow, as you can see. Same morphology, yes. Alright, that's good. ST segment. You'll know ST as in reference to myocardial infarctions. Is it on the isoelectric line? In this case, the isoelectric line isn't perfectly on this red line, so it's actually a little bit below. But in this case, yeah, looks like it. So it's not depressed, it's not elevated, it's not depressed. Alright, T wave, same direction as P wave. In this case, yes it is. And accessory, where is the pacemaker? So in this case, the pacemaker appears to be the P wave. It is preceding each QRS complex. It seems to be directing the impulse pacemaker present. So this, any hemodynamic correspondence, as in you can look at the electrical activity here, but remember, where did I put it? Or remember one of the 4 properties of myocytes, contractility. So that's the mechanical output or the response. So while the electrical activity might be firing, the actual mechanical output may not be, foreshadowing PEA. So you want to actually take a look at the patients themselves and the vitals. Is it actually happening? Are the contractions occurring? The impulse is occurring, that's fantastic, but ultimately we need the vital signs to back that up. Alright, so all of this is the 7-step method into interpreting ECG. And remember that ECG findings are typically considered significant if they are seen in 2 or more leads. So essentially, remember back to the elephant drawing. If one person says, hey, this elephant has an injury on its leg, we need someone else to back it up and say, oh, yeah, he has an injury on his leg, right? If these findings are seen in leads that look directly at the affected area, so let's say I'm on the side of the leg, of the supposedly injured leg, that's an indicative change. And if findings are seen in leads opposite to the affected area, so let's say someone was on the other side of the elephant and they see it as well, it's called a reciprocal change. Also mirror image, because the deflections will be inverses of each other. Alright, a lot to take in. Feel free to pause this at any time. My mouth is getting dry. Alright, so now let's actually talk about what each of these actually mean. So we talked briefly about how they're generated, but what do they actually correspond to mechanically? So I'm going to break it down into the P wave, the QRS complex, and the T wave. And the QRS itself, I'm going to break it down into the Q, R, and S waves. So starting at the P wave, what does it represent? Well, it represents the summative SA node impulse from right to left atrium, indicating atrial depolarization. Okay, what the hell does that mean? Well, first of all, what do I mean by summative? Like, why is the P wave a summative wave? Well, that's because it's the total reading of multiple impulses generated by the atrium. So as you can recall, look at all the internodal pathways. How the hell do you know which one you're capturing? You don't. In fact, all these branches coming off the SA node, it spreads into the right atrium, across the Bachmann's bundle, into the left atrium as well, like the 3 internodal pathways. Individually, they're not strong enough to generate that, but together they can. And that's a zoomed in image of this concept. So together, the collective impulse generated from all those pathways gets you a P wave. And remember, this is the mean, the average picture. So it occurs in the direction of the impulse, right? Because your atria is here. Alright. So why are they round and not peaked like this? I'll give you a second to think about it. Okay, second's up. So these, and why is it shorter than the R wave? Well, these two questions have the same answer, and that it's the atria that's smaller. It's a lot smaller than the ventricles, right? And so since they're significantly smaller than the ventricles, and they therefore generate a much smaller impulse that's actually capturable. And, well, furthermore, the sum total creates a mean vector that's not as apparent as ventricular depolarization. But all that isn't as significant as it might seem, because you can stretch this piece of paper and even this R wave is going to look round eventually. The other way around is true. If you squish it this way, then the P wave is going to get sharper and sharper. So it's not clinically significant. Yeah, just food for thought. So, summative SA node impulse, right to left, and during this time, so it indicates atrial depolarization right here. But remember, that's the actual electrical activity. The mechanical contraction, or the atrial kick, occurs during the PR interval. This whole thing. So it's the complete atrial depolarization plus conduction to the AV node, that is the PR interval, so right here. So the segment represents the slight delay, right? Because the impulse, whoops, I gotta clean this up a bit. So the impulse is slowed as it travels to the AV node. And the reason why it's slowed is because it gives the ventricles enough time to eject all of its blood before it can accept another round. Right? So that's why it's isoelectric here. That's the duration, that's the amplitude of normal physiology. And let's move on to the QRS complex, the big one. So QRS complex as a whole, it's a narrow complex, right? Very narrow. It represents conduction from the previous AV junction, so right here, through the bundle of His, left, right, bundle branches, and then the Purkinje fibers. Let's break it down. All right. Q wave. It's the first negative deflection before the R wave. Excuse me. So it's the first negative deflection, or it could be positive, before the R wave, including the momentary return to baseline. So right here, and then plus this part where it meets the isoelectric line. Similarly, the R wave is the first positive deflection following the downward deflection back to baseline. So that's that. And what does that represent? Well, the Q wave represents conduction through the interventricular septum. So right here, from left to right. And remember, if it's, imagine we're looking at it lead 2, so that's negative, that's positive. If it's going left here and going right here, it's kind of perpendicular, but it's, remember, the left ventricle is heavier, it's bulkier, it has a stronger impulse, so the net vector kind of angles this way, and it's kind of away from the positive. You can see how it's like, it's not perfectly away, like it's not like that, but it's a little bit angled away. And since it's only a little bit angled away, it generates a tiny deflection downwards, right? So it's slightly away. Normal physiology, it's less than 1/3 of the R wave. So if that's the R wave here, as you can see, that is far less than 1/3 of that. One small square, very narrow. R wave, the big one, represents ventricular depolarization where the net vector favors the bulkier left ventricle. So the ventricles are depolarizing. So they depolarize this way, this way, this way, this way, this way, this way, in all directions. And remember, in lead 2, we look at it like that. This side is bigger, so most of the impulse is captured this way. So if you were to take the average of all of these, it would be angled this way. So that's the average. And look at that. These two kind of look alike, right? If that's the lead, that's the mean vector. Same direction, positive deflection, a big one at that, so it goes up. All right? S wave represents Purkinje fiber activation and ventricular depolarization in the bases up here. So remember, the impulse has to travel up here as well, away from the positive electrode. So again, negative here, positive here. If we're looking at it like that, it depolarizes not perfectly perpendicular, a little bit away, hence you get a little bit of a negative deflection. Excellent. Finally, the J point, that's the junctional point where the QRS complex ends. So, oh, and the ST segment begins. So the T wave is that bump afterwards. So right there, right there, there. So it's the junctional point, so wherever the complex ends, and it hopefully matches the isoelectric line. And you'll see why that's clinically significant, because if that's where the ST segment begins, I wonder where you start measuring for ST elevation. All right. What's not shown here is a U wave, right there. U wave, it's a small waveform, obviously. Um, it's hypothesized that it represents late repolarization of the Purkinje fibers up here. So since it's occurring away from the positive electrode, it generates a positive deflection. Remember, it's the opposite of a depolarization, right? Same reason why the T wave is positive. But it's typically so small that more often than not, you don't see it. But you can imagine if it's there, it's whether or not it's there doesn't change the fact that the Purkinje fibers are indeed repolarizing. So try not to look for the shapes or memorize the shapes. Look for the concept. All right. T waves. Last wave. So ST segment measured from the J point right here to the start of the T wave right here. So it's this point. Remember, segments follow the isoelectric baseline most of the time, not including the wave. That would be an interval. It represents early ventricular repolarization, where contraction is maintained to expel ventricular blood before the T wave. Early ventricular repolarization. Okay, and the T wave, so this is where calcium is coming in. Remember this part? So it's early repolarization. Calcium comes in, maintains it. Okay. Where was I? Right here. T wave represents ventricular repolarization consisting of two halves. So this is the part where we have the absolute refractory period right here and the relative refractory period right here. It's less than half of the overall height of the QRS complex. That's true. And it's in the same direction as the P and R waves most of the time. Alright, so if that's true, then the relative refractory period, it's the most vulnerable part. It's the area where a partial depolarization is enough from a strong enough stimulus is enough to trigger another depolarization. So this is like a ticking time bomb. Whereas the absolute, over here, no depolarization occurs since the ventricles are not done repolarizing, so it's like attempting to flush a toilet that's still filling. Alright, TP segment, so end of the T, all the way to the start of the P. This is your isoelectric baseline. QT interval. Q, R, S, T. So it goes from here to here. Alright, and that represents all electrical activity from the moment ventricular depolarization starts all the way to the moment where ventricular repolarization ends. Okay, so it's like the whole journey of the ventricles. And we already went through with the U wave. Alright, that would be it for ECGs and the cardiac. So we went through the cardiac anatomy, conduction, we went through ECG theory, interpretation, and we went through the physiology, and we broke down normal sinus rhythm into its constituent parts and explained what each of them represent. So now, next week, we're going to get into the fun stuff. How all of this can go to shit.